Great. Well, thank you so much, Amber. And thank you for inviting me and having me here, and good morning. It means a lot to be able to talk to all of you. This is an audience outside of my traditional audience, I guess, that I speak to. So I'd love to have a conversation along the way. So if there's anything that I say that's not clear or that you'd like to have a conversation around, I'd love to do that as opposed to me talking without really clarifying what I'm trying to explain. So please feel free to ask questions. And I think it in many ways means a lot to have your attention on this topic because as we just learned, the impacts we're seeing from climate change is affecting the people who did the least to contribute to that. And I think there's so much that those communities can gain from just getting the right attention and the countries in the global north can play a big role in providing that attention. So I'm really fortunate and thankful that I'm here and that you're here learning about this. So the work that broadly we do in my research group is to think about how environmental variables affect kidney health. We all have 2 kidneys, hopefully. There are many kinds of reasons why not everyone has 2 kidneys, but generally those are organs that the medical community has paid less attention if you think about all the different diseases around the world. And that's been really highlighted in this work that we are doing. And I think this work has brought attention not just from our research group, but many, many research groups around the world to emphasize the importance of thinking about kidney health as a potential health indices or index for changing environments. And that's one message that I'd like to have you all walk away with. So broadly speaking, I think we all know that environmental change can have pretty significant health outcomes, affect our well-being. This is a figure from WHO, which outlines some of the environmental variables that can impact health. If you just think about chemicals as a variable, there are about 60,000 to 150,000 chemicals in circulation in the environment. And we probably know less than 10% of them in terms of what they do to our health. So there's a huge knowledge gap just in that one variable alone. And there's an article in Lancet that indicated that about 9 million premature deaths can happen from environmental pollution in the world. And now this is combined with a number of other stresses, but it's also with climate change. We're beginning to see intensifying health effects. And again, those health effects are most prominent in communities that need a lot of attention. And the work that I want to share with you today is covering some of these environmental variables that WHO has recognized as environmental risk factors or risk factors for people's health. So thinking about water sanitation, chemicals in the environment, occupational risks, agricultural practices, and of course, climate change. So I just want to highlight this up front that I think the work that I want to share sheds light on how important it is to think about these environmental variables as a driver of our own health, if that wasn't already clear from the previous presentation. And I think we are learning more and more every day that climate change is in fact intensifying many number of these health risks, especially the environmental health risks that's leading to this emergence of sentinel communities, communities that are already seeing changes in their own health and well-being that are in many ways disproportionately impacted by the environmental changes that are taking place. And that's the work that I want to highlight by talking about this particular form of kidney disease that was already mentioned, thankfully. I should say the keynote address really set me up for the work I want to share, so thank you for that. So what I want to talk about is this particular form of kidney disease called chronic kidney disease of unknown etiology or uncertain etiology or non-traditional origins, and depending on whom you talk to, it's also called Mesoamerican nephropathy or chronic interstitial nephritis in nephropathy in agricultural communities. So many number of acronyms, but generally we go by the term CKDU because there's a U that signifies the uncertainty around it. And the New England Journal of Medicine recognized this as a quintessential climate disease and a sentinel disease, indicating to us that perhaps the rapid environmental changes we are seeing, especially with heat stress, may be contributing to this, this disease. But there are also other variables through climate change that can contribute to this. Obviously, this has gotten a lot of media attention over the last 10 to 15 years. NPR ran a story in, about 10, 12 years ago, focusing on Mesoamerican farm workers who are working in sugarcane farms who are impacted by this disease. This is a New York Times article that highlights our work in Sri Lanka that also speaks about the impact that this disease is having on communities that are seeing what's going on. Right. So an article in Time magazine went as far as to say that this disease and chronic kidney diseases in general are poised to become the black lung of climate change. One thing that all of these articles have highlighted is the vulnerability, again, of the communities that did the least to contribute towards climate change. But what these articles are generally capturing is the sense that people who work in the outdoor environment under strenuous labor conditions are at risk of getting some level of kidney damage that might be intensified by some of the other occupational risk factors that they're exposed to. So I want to dive a little bit into some of those details and walk you through some of the work that we are doing. But just to explain what the kidneys do before we dive too far into it, I think of the kidneys, as much as I like them, and I think they're one of the coolest organs around, it's kind of like your trash processing facility, right? Pretty much every metabolic waste product that your body's produced filters through the kidney. If you take a medication, it might be metabolized in the liver, but the waste products come through the kidney. If you're exposed to environmental contaminants, they come through the kidney. So the kidneys filter about 200 liters of blood a day and about 2 liters of water that contains a bunch of waste and toxins. And that makes the kidney pretty sensitive to environmental burdens, especially to chemical burdens. Right? This is what a kidney looks like. This is where the blood that's full of waste coming into the kidney, and it goes through this very intricate functional unit. That's actually a remarkable evolutionary outcome, I think, that can filter out the waste in a way that we can reabsorb some of the important elements along the way and then excrete out the metabolites and chemicals that we don't need to keep in our body. Right? One of the other important part about the kidney is that it's one of the organs that operate under really low oxygen conditions in the body. So, you know, the sort of sensationalized wording people have used is the suffocating kidney, because of the way that the circulation system is set up and the vasculature is set up around the kidney. There's less oxygen going into this inner medulla part of the kidney. So the way that the kidneys work is there's an oxygen gradient. So some part of the kidney gets a lot of oxygen, some part of the kidneys get less oxygen, and because of that, if there's some kind of oxygen limitation, that inner part of the kidney can be susceptible to damage that can happen from reduced oxygen levels. So why does this matter? Sorry, I skipped a slide ahead. This is becoming important because as environments warm up, as we are exposed to heat stress, what happens in our bodies, we vasodilate. So our blood vessels get closer to our skin, and we also try to sweat a lot and try to evaporatively cool our bodies. And in that vasodilation process, there's less oxygen that can go into some of these deeper tissues. So under heat stress, not only you may have dehydration that can also pose a threat to your kidney, you can also be damaged or experience damage from that lack of oxygenation or reduced oxygenation coming into the kidney. So in some ways, kidneys are sort of under multiple threats from a heat exposure event. So you can have a low oxygen insult, you can have this direct heat injury that can happen, and then there's dehydration. And that coupled with the potential exposure to chemical insults in your environment, or if you're taking some kind of medication that can be pretty nephrotoxic or toxic to your kidney, all of that can combine to pose a threat to your kidney health. And so we think about this as, as the clock ticking for your kidneys under these changing environmental conditions. When we think about kidney diseases globally, more than 800 million people are at risk of kidney diseases. About 1.2 million people die annually from kidney failure. And currently about, I think it's considered the 12th leading cause of death in the world. And it's projected to become the 5th leading cause of death by 2040. And there are a number of risk factors that we've identified over the years that can contribute towards kidney diseases. So diabetes, hypertension, your genetic background, family history, exposure to infections, autoimmune diseases, medications, and also aging. All of that can contribute towards declining kidney functions in a person. Right? So there's already this background kidney issues going on around the world. And to add to that is what we see, this chronic kidney disease of unknown etiology that's come up. And what's unique about CKDU is that typically when you see a kidney patient in the hospital from your typical risk factors, you're seeing someone likely above the age of 55. And in this case, we're seeing patients dying even at the young age of 35. People are getting diagnosed at that really young age and progressively getting worse very quickly compared to some of the other forms of kidney diseases. And almost all cases, and by definition, they're not associated with any other typical risk factors that you would see in people that are likely to get kidney diseases under traditional circumstances, right? So these are people with pretty healthy lifestyles, we think. They look healthy, they are able to work normally, and one day they show up to the hospital and turns out their kidneys are at stage 4 kidney failure, which is one stage below complete kidney failure, which is essentially a mortality outcome at that point. And what's unique about this disease also is that often men are impacted compared to sort of equal distribution we see in typical kidney diseases. And in India, there's one community we work in, they describe this as the widowmaker disease because of the number of men that die from this kidney failure. So just to give you some numbers, about 90% of the people who are impacted by this are in farming communities, and about 60% of them are actually farmers. There's some individuals in a community who may not be involved in farming, but generally 90% of the people who are impacted are farmers. And when you look across globally, what you see is that about 1 in 3 men are at end-stage renal failure in this one community in Nicaragua. In this one community in Udanam that we've done some work in, about 60% of the people are diagnosed with this disease. There's been a 5-fold increase in the number of people dying from CKDU in El Salvador and Nicaragua over the last 20 years. And in Sri Lanka, where we do a lot of work, in a given time, there's about 20,000 people at end-stage renal failure. So they don't really have an option other than getting a kidney transplant, which is quite unlikely, especially in the communities that you think about. So where is it emerging? Just to think about the prevalence of the disease. This is based on hotspots that have currently been published. And where we see the disease most predominantly occurring are in Mesoamerica, so Mexico, Guatemala, El Salvador, Nicaragua, Costa Rica, Panama. All of these countries have reported incidences of CKDU. In Sri Lanka and India, there's been extensive reporting on this disease. And then we're beginning to see work coming out of East Asia. So Thailand, Cambodia, Vietnam, we're beginning to see this emerging. I was just in Kenya where we are beginning to start, we're starting a new cohort there to look for this disease, but there's some evidence that it might be in Kenya as well. There's evidence coming from Egypt and Ghana and Ethiopia and several other countries in the African continent. And then there's evidence emerging showing that in the United States, especially in some of the hotter parts of the United States, like Texas and North Carolina and California, we're beginning to see that this disease is emerging. Right? And there's work that's beginning to start looking for, more extensively looking for this. So what's correlated with this disease? All the epidemiology work that's gone on over the last 30 years points to two things: exposure to heat stress and exposure to environmental contaminants. So it was first diagnosed in El Salvador, and right around the same time, there was a community in Sri Lanka that also started reporting that this disease is emerging. And it took about another 10 years before anyone started paying attention to it. And then there's been this sort of rapid increasing in the number of papers coming out on this work, with quite a lot of research going on to understand this in the last 5 to 10 years, I would say. Right. So all of that work, if you look across the board, you'll find that the common theme is that these are people who work in agriculture, who are exposed to agricultural chemicals, and they conduct strenuous labor activities in their environment, as obviously they're part of their work. So to start thinking about this disease, we set up all of our work in Sri Lanka. It's a beautiful island, and I'm not biased, of course. And I grew up right here in this little town. Right around that area that I grew up is one of the wettest part of the country, so we call it the wet zone. And then what you see here in pink and red, that's the dry zone of the country, which is also the hottest part of the country. And it's also where this disease has emerged. So if you look at data from Sri Lanka, some of these communities that are dark red, those are the areas with the highest disease prevalence. So somewhere between 10 to 20% of the people in these communities are experiencing this chronic kidney failure. There's some of these disease incidents being reported in some of the lighter pink areas, but generally some of these hot, warm areas are considered the typical hotspots for this. So to do this work, we chose Sri Lanka, obviously partly because I'm very familiar with the setup, I speak the language and all of that, but also Sri Lanka provides a pretty sentinel location for studying this. There's a really highly organized public health system in the country that dates back to about 50 to 80 years, depending on how you look at it, that has health records in hospitals. So you could actually track back and see when did we start seeing this disease emerging. The country generally, there's a lot of public awareness, partly because of high literacy rates, about 95 to 99% literacy rate, depending on which area you're in. And the government's done a lot of work to try and educate the communities about this disease and has allocated a lot of resources to understand this. There's generally support as a researcher when you go into the country to do the work. One of the key features of this disease in Sri Lanka is that compared to South American cohorts or communities where sugarcane farming is most associated with this disease incidence, in Sri Lanka, this disease is associated with rice farming. So it's not the same type of farming that we see. So there's an interesting difference that pops up there in some cases. Just to show you the places we work in, that's what a community looks like. Even though it's hot and dry, when you go there, it's actually really beautiful and serene and calm. You wouldn't think that this is a village where 20% of the people are dying from kidney diseases. It's also almost become normalized when you talk to anybody there. Everybody knows somebody who died from CKDU or who has CKDU, and they would tell you, oh yeah, so-and-so this happened, and it's kind of a normal thing to do. And one thing that we've done over the years is to build really strong community partnerships to work with the people there. So two of the folks here, this is Chamal Priyanta, who is a physician who was born in that community and went to medical school, and is the first and only person to go to medical school. From then, he's done a ton of work with us to help bring awareness, but also do the community work. His mom just died from CKDU, so he has a personal interest in understanding what's going on. And then this is Mr. Saman, who's one of our other really important community members, who's really helped us to develop a program in his community to start screening for this disease. He's holding my son on his shoulder, so I joke with him that he has my whole family on his shoulders, both my career and the future of my kids. And I should mention that to do the work, we obviously, Duke University has put in a ton of effort to promote and elevate this work, especially through my appointments at the Global Health Institute and also the School of Medicine. And also University of Ruhuna is a university that's in the southern part of Sri Lanka. Professor Mangala de Silvas has been a key ally and a researcher there who's helped us generate a lot of work. And we also set up a nonprofit in the country that allows us to do a lot of this work, which is critical especially in getting through events like the pandemic that happened. And what we've done is try and set up this sort of interdisciplinary framework to better understand what's going on. And I am trained as a molecular toxicologist and also a heat stress biologist. That was my PhD, was all about understanding molecular effects of exposure to heat stress. And that expertise come together in trying to understand what might be going on with this disease at the cellular and molecular level. We collaborate a lot with epidemiologists and exposure scientists to try and understand all the different environmental elements that might be contributing to this, and then try and have meaningful engagements with the community, and also train some of the local physicians and community leaders to be able to carry out some of the citizen science type work that they can do. And also through our nonprofit, we've been able to interface with the government on policy action on some of this work. So what I want to show you is some of the work we've done to define environmental exposures in these communities. And the reason I want to do this, I think, is to highlight some of the questions that came up earlier, is that how do we know for sure if something is causing a disease, right? And when you think about an infectious agent like dengue, for example, we know that we can measure an antibody in our body to know that you've been infected by the virus. In the cases of environmental exposures, that's been our biggest challenge, because these exposures, an exposure today doesn't lead to health outcome this afternoon, right? It may take a lifetime, it may take generations. And that is the biggest challenge that we have as environmental health scientists, and that's obviously reflected in the questions that we got earlier. So one thing we are trying to do is to extensively characterize the environment and try and correlate that with kidney health outcomes. But I would be the first to admit that we will have to do a lot more work to be able to really define this exposure is what's exactly causing this disease. But what we want to highlight is that these are communities that are at high risk, and there's enough sufficient correlation for us to take action. So one thing we've done is to put in these silicone wristbands around people in the community to be able to get a signature of all the different aerosolized contaminants, especially the organic polar compounds that stick to those silicone wristbands, so we can get a sense of what are the different chemicals that these farmers might be using, what are they exposed to in their daily life. Then we also extensively characterize their drinking water samples. As I mentioned, kidneys are sort of that waste processing facility, right? So these contaminants that we are exposed to, many of them can filter through the kidney. And then we also try and measure heat exposure in these communities. And I'll highlight the work we're doing with the water sampling and also with heat exposure efforts and not the wristband work. Just to dive into this a little bit, it's led by two really wonderful postdocs, and now they've gone on to become their own researchers back in Sri Lanka, who led this work and continue to lead this work. So what we did was try and map heat exposure in Sri Lanka. So we looked at the last 40 years of, I think it's actually 43 years of data from what's called the ERA5, which is European Reanalysis data set, to try and map what are the average monthly maximum temperatures that community members may have experienced in the country, depending on where you live. So the darker it is, the more hot it's gotten. The lighter it is, you're living in a nice, cool area of the country. And we looked at multiple different occupational groups to try and understand kidney function in these occupational groups. These are all done as sort of independent studies, but I'm going to show the results together just to show you some of the trends we are seeing. So one group of people, obviously, we focused on are farmers. So we focused on farmers who live in the cooler part of the country and farmers who live in this kidney disease impacted region. We then also focused on fishermen, and these fishermen in Sri Lanka, they're not your typical fishermen in the US where you have a really nice big boat and you just start the motor and go in. They actually have these really tiny little boats where they actually have to row out into sea and throw a net around. So it's really extremely hard work that they have to do, especially if it's a choppy day, right? I tried to do it and gave up pretty quickly. So, and then we also focused on salt pan workers. So this is a salt pan. I don't know how many of you know what a salt pan is. It's salt pans produce about 10% of the global salt. And these are these really shallow pools near the coastline, of course, where you let seawater come in, and then you let the seawater evaporate. So it has to be really hot. So the water evaporates, and now you have this crystallized salt, and then there are these workers who would go in and just harvest the salt out from the ground, wash it off, and then sell it in the market. Right? So salt pan workers here. We also have a community up in the north, and then fishermen coming from the northern area, and then farmers from a kidney disease impacted region, and also farmers who are working in the cooler parts of the country. So comparing all of them, I just want to quickly highlight what we found was, and I'll show you the data in a second, that salt pan workers are at the highest risk of showing kidney dysfunction. So this is some pictures of what we've done or when we went there. We monitored about 320 workers, I think, and we're continuing to monitor these workers. And what we found was that about 85% of the salt pan workers who actually are in the pan digging out salt, show that they're at stage 2 risk of getting chronic kidney disease. Only about 15% of those salt pan workers had normal kidney function. And then about another 15% are already at stage 3. So if you're at stage 3, if you're at stage 2 in kidney, sort of the kidney disease literature or kidney disease space, you could go on medications and try and maintain the disease or even recover. Even stage 3, you're okay. If you go to stage 3B and beyond, things start to get pretty bad for you. So we are capturing them at a stage where we could actually do an intervention. And the question is, what intervention should we do? And this goes back to the question of how much should we know before we do something, right? So there's a slight difference between male and female, but generally it seems that many members of over 80% of the members of this community experience declining kidney function. And this is at the end of a season of harvesting salt. So when we compare all of our data from across multiple studies and just plot it all together, and I did it just for this presentation today, we can see that salt pan workers who work in some of the hottest parts of the country show the most decline as a population in their kidney function. So the red dotted line is sort of your normal, healthy kidney function. and anything below that is showing decline in kidney function. And the salt pan workers not doing so well, and then we see that paddy workers, or the rice field farmers, they're showing declines in kidney function. But as you go towards cooler and cooler climates in the country, you're beginning to see that the kidney function increases. We don't have salt pan workers in cooler parts of the country, so we can't study them. But fishermen and farmers who live in cooler parts of the country, they don't show this decline in kidney function. And I think this is fairly strong evidence for us to suggest that heat stress is directly correlated with this decline in kidney function. What's interesting, though, is that when we look at CKDU incidence, this incidence of unknown kidney disease, the salt pan areas show very low prevalence, whereas the farming communities show really high prevalence, even though they're not the ones who are exposed to the highest level of heat, and as a population show the most decline in kidney function. So in other words, everybody here is at risk, but some here show, a fraction of the population here show really poor decline in kidney health, right? So the general conclusion we make from that is that just by working under hot conditions don't necessarily lead you to this complete kidney failure. At least that's what the data is showing to us from Sri Lanka. But it's a major risk factor, because when we look at farmers who work in cooler regions, we don't see the same decline in kidney function. But we see this in farmers who work in hot regions, but they're also exposed to something else that makes their kidney go even worse under worse conditions, right? So that's why we were motivated to look across for different chemical contaminants. And I just want to show you the water sampling data that we did. And this is the different sources of water that we've tested. A lot of these folks drink water from these dug wells. They just dig a hole. So this is a drinking water well, for example, right here. And people just dig a hole and get water from it. What's unique about these water wells is that they're often right next to their rice field. So whenever they go spray their pesticide or weedicide, that water just directly comes right through their drinking water source. Right? So we've sampled hundreds of wells in these communities. And the reason we really focused on water is, one, it's obviously a source of exposure because people are drinking this. But also, it's a snapshot of what is being captured in the environment. Right? So this is one study we did comparing CKDU hotspots and non-hotspots. This is a thesis work by one of the PhD students. And what we found was that the chemical burden in the wells where the disease prevalence is high is a lot higher than the chemical burden in the regions where the disease prevalence is low. And when we think about the chemicals, we find metals, various kinds of metals, metalloids, fluoride, and also water hardness, so it's calcified. If you've ever seen sort of your drinking water tap calcifying around the tap, that's showing hard water in your water systems. And all of that is also correlated with one particular pesticide called glyphosate. Glyphosate is the key ingredient in Roundup. It's probably it is actually the most sold pesticide in the world, including in the US. It's heavily used all around. And we find that glyphosate is the presence of glyphosate in a drinking water sample is highly correlated with disease incidence in these regions, which was surprising to us because of some of our work and others' work. The Sri Lankan government banned glyphosate export into the country. And we went and did this work about 5 years after that ban happened, or 4 years after that ban happened. And in theory, glyphosate should disappear from the environment within 7 days to a month. And we were still measuring this in these regions where this disease is prevalent. So somehow the environment is enabling this compound to stick around in the drinking water sources. And we think it's the hardness, and there's some ideas around why that might be, that's enabling glyphosate to stay around in the environment. And we're doing a lot of work now to try and understand, is this a molecule or chemical that's toxic to the kidney, and how and why is it important to be in the presence of cations like calcium and magnesium that may increase the toxicity to kidney, but also how does heat stress interact with that. One other point I want to highlight is that not only there was glyphosate, we did what's called a non-targeted chemical analysis, and this highlights our problem as environmental health scientists, is that you have these technologies now where you can go and broadly screen for anything in the water, where you don't know what the chemical you're looking for. You just get a whole bunch of data, and then you compare your data against a database, and you can generate a figure like this, where each one of these lines is a chemical, and each one of the rows is a drinking water source, right? So you can have thousands of chemicals in a drinking water sample. Some are naturally occurring, some are anthropogenic, some are geogenic, and when we look through that water sample, we find there are surfactants, which are these chemicals you use to dissolve your pesticides, for example. Pesticides, also pharmaceutical compounds, which might be coming from the drinking water source being connected to the toilet that's right next to it in these communities. We're also finding chemicals that are related to personal care products. Again, indicating that these communities consume a really complex mixture of chemicals, even though we didn't measure anything that would be considered toxic at the EPA level, or EPA regulatory level, or any kind of the regulatory thresholds that the world's described. Which brings into this point again, how do we ever know for sure? And just because it's below the EPA regulatory level, which is defined based on single chemical analyses, should we discard this kind of data, right? So I think we are fairly confident that environmental chemical exposures and heat stress are two risk factors that are associated with CKDU. But I think when we think about what should we do about it, right? Can we remove this risk? If you go talk to a farmer and say heat stress is associated with your declining kidney function, they're not going to stop working the next day, right? They will keep working. But they will want to know, at what point should I stop working? If you tell me exactly when to stop, if you tell me the threshold for my heat exposure, obviously they wouldn't use the word threshold, but if you tell me the threshold for heat exposure, I will stop working for a little bit, but I'm going to go back and keep working, right? So there's that factor, because as it was mentioned earlier, there's food insecurity in these communities, right? So if they don't produce, sorry, maybe two slides got mixed up. Sorry, this should come first. But there's food insecurity in these regions, and if they stop farming, there are bigger problems than kidney failure that can happen, right? So they're not going to stop farming just because we tell them, okay, heat stress is a problem. They're not going to stop using chemicals because we tell them these are bad for your kidney health. The other part is we worked with schools to provide clean water to the schools so that at least the children can have access to uncontaminated water sources. But we found that the girls in these schools wouldn't drink the water because the toilets are not good enough, and they wouldn't want to actually consume water while they're at school. So they might bring a bottle and take the water home, or they'd never drink this water. So often women were dehydrated, young women we found to be dehydrated. And then that's related to who can afford access to clean water, right? Who can afford to buy a water filtering system, and who can change the water filters in a timely manner that can get them access to clean water. So I want to go back to this slide real quick, and while it's really challenging to remove risk, we have to understand answers to some of these questions, at least to be able to convince the communities and then obviously the policymakers to say, if we understand these factors, at least we can do something about it. So one is identifying the threshold for heat exposure. The second part is understanding how does heat interact with some of these chemical contaminants, both in the environment, but also once it's entered your body, right? Does your body respond differently to the same chemical if you're exposed to it under dehydrating hot conditions versus if you're working in a farm in Maine and under colder conditions, right? We see this in Sri Lanka because the same agrochemicals are used throughout the country, but the disease is only localized to regions that are hot, not to the rest of the place. And the other question that keeps coming up is, can we catch this early? Can we do something about it so the next generation don't get it? And that's where this work comes in, where we've now been working with 3,500 children cohort that we've established in Sri Lanka, and we've been following them for the last 2-3 years. We do this through schools, and we are comparing kids from multiple locations where the disease is already prevalent, and regions that are cooler versus warmer, versus the disease is endemic or non-endemic. And broadly speaking, what we find, to your earlier point about children at risk of this, we find that kids between the ages of 10 to 17 living in these CKD impacted communities, both in Sri Lanka through our work, but also work in Mesoamerica that others have done, show that kids already show poor signs of kidney function. So kidney function is starting to decline early in these communities compared to what you would see here in Raleigh, for example. Our second question around defining thresholds. I showed you this map earlier. This is looking at average monthly maximum. But we could also look at how much has heat exposure fluctuated through the last 40 years. We could also look at the rate of increase, and we can look at the number of days that people spend outside working under conditions that exceeded the thresholds already set by WHO. And depending on which parameter you look at, you find that certain people in certain communities may be at differential risk levels, right? So you could be here and probably the safest area in the country, but anywhere else you may be exposed to heat exposure in different ways. And we don't understand how these different variables around heat stress actually affect our health. And that's a major, major gap in the field. A second gap that again exemplifies this idea or notion around communities that did the least are suffering the most is that the European reanalysis data that we've downloaded and some of the other data sets that we've looked at, the data we get from the satellites do not correlate with what we measure on the ground. There's a big discrepancy, especially when we think about extremes. So this is showing the satellite data in black, or reanalysis data in black, and in red, what we are seeing, the ground monitoring data based on equipment that we've set up and the Sri Lankan Meteorology Department set up. And you can see the heat extremes are not captured on both ends by the climate data. So when you look at those global maps, they're amazing. They tell us a lot, but they also might be completely underestimating the risk to especially some of these low middle income communities that are not able to provide the same level of ground monitoring data to validate the climate models. And that's causing, obviously, a huge issue, especially when we think about who's at risk of being heat exposed. The third part that we don't understand with heat is that what does environmental heat exposure mean for your body? We need to do a lot more work around monitoring our own physiological measures to correlate what environment is showing to what your body might actually be doing. And that's work that's ongoing. We're really excited for this work. We have these chest straps that our farmers can wear, and they tell us core body temperature, sort of. It's the best we've got. And then we can measure their heart rate and skin temperature, and we have these data monitoring stations set up that we can ground through the satellite data. And our hope is that through this kind of continuum, we can get a much better sense of how environmental data correlates to physiological measures of our farmers. But this still doesn't get at these two big questions that keeps coming up, is how does heat affect physiological response to toxins? And that's something we can really only do in the lab, and taking that to the field is almost impossible. And then how does environmental heat and some of the other climate factors actually change the exposome in the external environment, the chemical environment outside of us? How do these variables actually change those? And those are the gaps that we're dealing with. And one couple of quick things I want to highlight is that tackling these require quite a bit of transdisciplinary effort. And for us, I've been very lucky to work with multiple of these pillars. So climate scientists, epidemiologists, lab scientists, which I would put myself in that category, analytical chemists, as well as clinicians and policymakers and educators. But the current academic system that we've got set up, which leads research around the world, doesn't necessarily facilitate this type of approach to address climate and health issues that are emerging. So that's an area I think that we really should be thinking about changing in order to address some of these more complex problems that we are seeing. So to wrap up, I'll say that in many ways we are scratching the surface of understanding how heat and chemicals might be affecting kidney health. What is really important to think about is that these exposures might be happening in childhood or even in pregnant mothers, as we've seen. And that might increase your susceptibility to some of the later occupational exposures that may happen as these communities live in their environment. And this matters not just to these CKDU communities, but also to everybody around the world. In the United States, there are about 37 million Americans who suffer from some form of kidney disease. About 50% of the US are diabetic and hypertensive, which means they're already at risk of some type of kidney disease or kidney dysfunction. So if you have some of these other environmental variables that can increase your risk, we really should be paying attention to that. And that's already been coming into focus, where we are beginning to see that, for example, heat waves are linked to 10 to 25% higher incidence of acute kidney injury and hospitalizations in the US. There's heat waves associated with 1.6-fold higher odds for any episode of acute kidney injury. In California, across workday, across harvest studies show that farm workers indicate high prevalence of kidney injury under high physical strain. There's also studies beginning to show that heat stress will amplify your pre-existing conditions for conditions that put your kidneys at risk. Right? So I think we have enough data to suggest and indicate that from the perspective of kidney health, we should really be concerned about heat exposure levels. Unfortunately, it's only a correlation, and this is a really brilliant point that was brought up earlier. We don't really have enough data to show causation, right? But do we need to show causation in these contexts? That's my dad, who has a little banana farm, I should say. He's diabetic, he's 70 years old, his kidneys are shot, and I convinced him to not work in his farm, and he sold it. Because he would go out and spend hours. I almost got heat stress from taking the picture. So he would go in and work in these farming areas. And I was able to convince him that heat stress is a risk to your kidneys, and he was able to sell it. But obviously, he's at a much more privileged position to be able to do that, and not everybody can do that. So the question that I leave you with is, how much do we need to know when we think about making a difference for communities who didn't do anything really to cause the changes that we're seeing in the environments? So with that, I want to thank a large group of people who I've been very fortunate to collaborate with, including our community partners. And also, again, thank you all for listening.
Thank you for a great narrative. Guys, we're going to work on getting the slides from his and from Chris's presentation to you, so don't worry about the teeny little details.
I'm so excited that you brought all this up, because this is one of my topics. And thank you for the last question, because that actually is the perfect segue for my question. Mexico right now, I'm from Mexico, it's having a really, really high epidemic of kidney disease. The difference is that our health system, it's a mess. We don't have the records to basically be tracking this. We don't have a lot of science to find, the causation. And as journalists, I think it's very, very important to tell this story and basically tell people, like, this is a risk. But when you don't have the data to show it, how can you do that? Because it's very difficult to extrapolate from one country to another. In Mexico, for example, health authorities, they tell us, it's your diet.
Yeah.
Because we have also really high rates of obesity and diabetes. Yeah. So how can you actually, genetics are very different from Mexican people and Asian people. Right. Any advice, or maybe we can workshop this, how can we tell this story and really convey the sense of urgency, that climate it's impacting when you do not have data?
Yeah. No, beautiful question. And I actually came hoping I'll learn from all of you the answer to that question. Because I think as scientists, we always go into this shell about we need to know more before we tell the decision makers what to do, right? But I think I go back to my earlier point about who's at risk. Can they afford to wait, right? And I think if you're trying to convince your government or your general population to take action, highlighting the existing disparities for the communities impacted and say this is the community that with these already baseline disparities that put these communities at risk, you add one more, that might be the straw that breaks the camel's back, right? So I think the narrative that I keep using is to say, heat stress, not going to do anything to me. I'm not an athlete, and I pretty much spend all my time inside, and I can afford to control my temperature, right? It's going to affect the farmers, it's going to affect the diabetic patient who can't afford insulin. So I think highlighting that disparity and convincing the regulators to say, you're adding one more item to the list of things that can affect these people. And that's the way I think we have to move the language forward around environmental health broadly, not just kidney health, but generally around how does the environment affect your health? Because as a clinician, they see a patient in the hospital, they can't change your environment. They can't tell you what you should do differently often. Right? They can try to get a sense. We were just talking about this earlier with Dr. Newman, but I think the change has to come from not necessarily just from your personal behavioral change, but at the policy and regulatory level. And I think using the narrative is the way I would go about it.
Thank you very much for the presentation. And my name is Rosalia Omungo from Kenya, science journalist from Kenya, but I also work with Kenya Editors Guild. And my question relates a bit about to what she asked about the Mexico case, about the lack of data, and mainly who's at risk. So in the Kenyan context, I see three sets of people at risk. Yeah. Those people living in the informal settlements, people working in the flower farms, but also communities where people just, when they settle somewhere, the first thing they do is to think about their provision of water. So they go for boreholes, right? So you find very many homes have boreholes, which they just dug without any assessment from any authorities. Yet that data is lacking. So the question would be, would this be isolated? Like when we have respiratory diseases or lots of diseases affecting people who work in the flower farms, for instance, is there a way in which this can be isolated and linked directly to kidney problems? Okay, is there data to show that? I think one of the issues for Kenya would be lack of data.
Yeah, no, I completely agree with you, and partly the reason why we were there this summer is the Duke Global Health Institute is really interested in putting forward effort to build an they've already built an East Africa partnership that includes Kenya, Rwanda, and a few other countries, and the goal is to start collecting this type of data through a data hub that they're looking to create. Because when you look across the world for CKDU, essentially, except for a couple of studies, African continent does not have the data that we would need. That's broadly for CKDU. What we've seen from Kenya, though, I would add two other risk factors. There's high HIV rates compared to some of the other CKDU-impacted communities, which poses a risk to kidney. And there's a mutation called ApoA1 that puts East African, I think in the US at least that's true, that black communities are at higher risk of kidney diseases because of this particular mutation. And the same thing exists in some of the African communities, although it's not uniform across the continent. So there's some way that it bottlenecked into having a higher prevalence in the US, but it also exists in the continent. So there are two other risk factors to consider when we think about this type of disease in Kenya. again, going back to the point you're both bringing up, and how do you parse out which disease is the one we should really care about and what's causing it? I go back to the same idea, is that when we think about vulnerable communities, we have to think about it in a collective. I don't think we could say with this disease we should cure by changing this. I think we have to think about what is the overall disease burden that this community is facing, and what are the environmental burdens that are associated with that, and how do we change and reduce that burden should be the narrative. Unfortunately, that's the best I got.
Two questions. First, the easy one. It seems you have flawed data from remote sensing. Can that be normalized to wet bulb temperatures and what's going on, not only in this context, but worldwide? And the second one is, do you have any ideas how to show causation, especially in light of all the confounding factors?
Yeah, great question. So with the data discrepancies that we see, we've only done the comparison for Sri Lanka. So it might be a Sri Lanka issue because we are a small island and the ocean might be playing a role in what the ground temperatures are, and that might be why there's this big difference that we see. So I was just meeting with a group from Singapore yesterday, and they're going to look at a parallel data set from their country, which are two similar locations in the world. If we see the same difference, then I would agree that there's flawed data coming through, and then there's a lot more work that needs to be done. But I am convinced that Sri Lanka has a problem. And to answer the second sorry, could you repeat the second question again?
Do you have any ideas about how to show causation,
Right.
especially since there's so much confounding?
Yeah, I think there's animal studies going on. There's a group in Florida doing this work. There's a group at Duke doing this kind of work. There's a group in Colorado doing animal studies with heat-exposed mice and looking at kidney dysfunction in animal models, which I think is going to be compelling enough to say we need to look closer in humans for causation. It's not going to be the answer, right? We cannot do things like dose response curves that we would do with a chemical exposure with heat. So there's quite a bit of rethinking that has to happen in how we would go about showing causation in this case. And there are some ideas we floated around. One thing we are doing is, this is a grant, so I shouldn't say we're doing it. One thing we are proposing to do with a group from Chicago, they've built these cooling clothing. And if we have our farmers wear the cooling clothing items, could we then show improved kidney function, right? Those types of intervention studies could help. There's studies coming from Nicaragua showing hydration breaks and spending time under shade for some period of time can improve kidney health outcomes. So interventions is one way to show that there is some level of causation going on. Yeah.
Are there any histologic biomarkers or others that can tell you whether it's toxic or dehydration or chemicals?
Right. Great question again. We've done work in urinary proteome, so it's not histology. People have looked at biopsies from these patients. The big problem with the biopsies is you don't get a biopsy until your kidneys are at stage 4 failure, right? So by the time you look for what's in the kidney, you're looking at a completely different picture of what's going on compared to what started the disease, which is why we're really excited about the children cohort. Obviously, we're not going to get kidney biopsies from them, but at least we can monitor them for a period of time. There are molecular markers of heat exposure. They're not great. And there are markers of kidney injury in urine we can look at. They're also not the greatest, better than heat exposure markers. So at this point, I think the field has to go a long way in try and identify what is a physiological marker of heat stress that we could measure without being super invasive. Right? There are other work on looking at histological changes in the kidney that shows that there's lysosomal damage in the kidney, which relates back to a potential toxin exposure as opposed to a heat exposed change that's going on. So I'll add that to the, Sorry,
Hi, I'm Ian. I'm a reporter in Idaho. I was interested in what you were saying about glyphosate and that Sri Lanka has banned it. I'm wondering, do you think there's any possibility that the ban is not being adhered to and that it's still being brought in? And if not, if you don't think that's the case and you do think it's the persistence through some other means, I'm curious if there's any research into that, because it seems like if that is the case, it's persisting much, much longer than is, supposedly it is based on,
Great question. And the reason why we don't think it's because illegal supply of glyphosate coming in is we are not measuring it in the southern and other parts of the country that uses even more, right? So we are only seeing it in this kidney disease impacted areas and not in the, excuse me, we need to change the climate, I think. Keep getting a dry throat. But the fact that Sri Lanka is very agricultural, and there's a lot of agriculture in the central part of the country where I showed you, like the cooler part of the country. They use more glyphosate than entire regions put together. And we don't measure it we measure it in the farmer's urine right after application. So it's obviously getting into them. We don't see kidney disease in the farmer, so they're excreting it out. So there's no persistent exposure. It might be just the acute exposure that happens, but it's definitely staying a longer time in the other regions. And there's work by the chemist that I worked with, Dr. Lee Ferguson, who was able to really develop the method to look for low levels of this compound. And their group is very interested in following up on this to see what makes it persist for so long. Because if that's true, there's quite a bit of change that'll have to happen. Yeah.
Hi, my name is Sarah. I'm a reporter at the Milwaukee Journal Sentinel in Wisconsin. I'm just curious what Sri Lanka is doing to address the disease and to what extent those efforts are aimed at the heat exposure part of it versus the pollution and contaminants. And I'm curious if there's been any efforts to completely remove contaminants in some group of people and see how they respond. If that's removed, would it even be an issue?
Yeah, no, great question. And I think the country's done a lot compared to a lot of the other CKD impacted parts of the world, both in terms of awareness, lots of free clinics set up. Sri Lanka currently holds the largest nephrology clinic in entire South Asia. So it's this massive hospital that's just to serve these patients. And there's a lot of effort going in through our work, through schools and others who are trying to educate the next generation about drinking clean water. The government, especially the Navy, has set up free filtration facilities so people who can't afford clean water can go get it from them. So there's effort, but there's no monitoring of that effort to understand, did that actually make a difference? So something I'd love to do is to actually do a full-blown community survey based on who has access to clean water and are we seeing a decline in disease in those regions. In terms of heat exposure, it's just emerging as a threat because of the attention it's getting. Frankly, nothing's been done, right? So, yeah.
Hi, my name is Janae. I'm one of the Sure Fellows here, and I work for Capital B News. I just had two kind of quick questions. First, how is the receptiveness of the community that you work with when you're, telling them this and trying to link these two things that even us in the scientific community are still trying to, kind of piece those puzzles together? And how receptive are they to prioritizing this in their lives, considering a lot of these things, these exposures are part of their livelihoods and their jobs as well. Yeah. And then my other question was just wondering if there was any kind of gendered proportion. I saw it looked about even for the salt workers, but I'm also wondering are there more male salt workers and women salt workers, et cetera, et cetera. So
yeah. Great questions. I'll start with the community perception and reception part. We've been very lucky so far to find allies in the community to do the work. And we partner with schools, but also we partner with farming cooperatives, and they've been able to help us gather the farmers for our work. The salt worker work, actually the company wants us to do it, which is great, which doesn't happen very often. So they are really leading the saying, we want to know if our workers are healthy. And obviously they don't want to be held responsible for occupational health hazards, so they're taking initiative. What we do worry about is if we do find someone has kidney disease, would the company then not hire them the next season, right? So that's a conversation we have to have now. But generally, we've been lucky to have the reception. Where I see the issue is that there's a lot of research going on. There are many research groups in Sri Lanka, including our group. So we find patients who've donated blood to this research about 30 times by now. And always they want to know, so did you find the cause, right? Do you know what's going on? Do I need to give blood again, right? So we've really switched to using urine as a biological representative sample because it is a lot easier to collect and people are much more receptive to giving that. And that's a whole area that someone, I hope, looks into, because we are putting these communities at even further sort of suppressed state by saying, give us more of your sample so I could go back to the US and give a talk about it, right? So that's the perception that they see. So to answer your last question about gender, in South America, there's quite a bit of a gender difference in this disease in terms of men versus women. In Sri Lanka, it's 50-50 almost, which is why we think our exposure route might be different. It might be coming from drinking water as opposed to occupational application, which might also be going on, but there's probably more persistent exposure happening through the drinking water. We haven't done any work to really understand what it means to live in a community where you know that 1 in 5 people will get kidney disease, right? And how does it influence your decision making and what you need to do? And that's, again, that's why I think we should really think about this from a social science perspective moving forward. Yeah.
Chris Russell, freelance. You said, members of the community come back and want to know what you found. How do you explain to the lay audience the difference between causation and association, and that you can't really say that it causes this? So how do you bring it down from a non-scientific audience to a community-based audience?
Yeah, the way I've learned to speak about it, at least in Sinhalese and with the communities you work with, is what basically I tell my father, right, is that you're involved in an activity that will further increase your risk of getting a terminal disease. So what can we do about it? And if it's an individual conversation, I try to learn about the person's capacity to do something about it. If it's a group of farmer and cooperative that we are working with, then it's more of a me telling them what are best possible solutions, like hydrating yourself as often as possible. Take breaks. If you can look at the weather, check the weather, and if it's the hottest day coming in April, then try and minimize your work hours, or go really early in the morning, take a break during the day, and then come back in the evening. So we are trying to give these kind of messaging, but I've never said, and I don't think anyone in Sri Lanka said, if you take away this risk factor, you'll not get the disease. We don't want to do that, I guess, because if you're wrong, and that's the dilemma of a scientist, then your entire credibility goes away, right? So we are trying to be really careful in the language we use to say all of these risks can affect your kidney health. The more you can do to avoid that risk, the better off you are. Right? Yeah.
Hi, my name's Deborah Blum. I'm director of the Night Science Journalism program at MIT. My question has to do with fluoride, which you referenced as, for political reasons in part, right? But which you referenced as a risk factor in kidney disease in Sri Lanka. My understanding is that's related to natural fluorine deposits, and the kind of fluoridosis that you're talking about is quite similar to what we see in the Rift Valley region of Africa, where we again have those high levels of fluorine deposits. I wonder if you could really clarify, because as you know, fluoridation is coming up as an issue in the United States under the incoming administration. The difference between what you think you see in Sri Lanka and what we see here in the United States with the much lower levels of fluoridation in water systems in our case. They're very different animals, and I'd really appreciate the clarification.
Yeah, you're absolutely right. The levels we see with geogenic, naturally occurring fluoride in Sri Lanka is way higher. I don't want to go into the numbers because I don't want to misspeak. higher than what we see in the levels of fluoride intentionally added to drinking water supplies. And we have a review paper that's currently in review that looked at all the fluoride literature and its association with kidney health outcomes. And there are many areas in the world where fluoride levels are really high, including the Rift Valley, where there is no kidney disease prevalence going on. There's fluorosis, fluoride buildup in your teeth. There's bone biopsies people have done to show there's fluoride depositions happening in the bone, but we still don't see kidney diseases. So fluoride alone as an agent of kidney health risk, I'm not comfortable in stating that. So.